I haven't used a handheld Doppler for many years because I use ultrasound every day and all day. But we have Denise Royal here from Vascular Technologies, and we're going to just look at what is a very useful method of adding a bit of science to a consultation. And I think those of us with ultrasounds won't necessarily need this. And I'm probably not as good as I used to be, but I used to use it a lot. And it's just to show, just briefly, and Denise, who as a company make these, has very kindly volunteered to put her shorts on. And I'm just going to show you how we use it. And Denise will correct me when I'm wrong, because we did spend last night discussing whether the Doppler angle was 60 or 45 degrees. And we did Google it, and in fact it's either, so it's an angle. So, Denise, well done. If you get air in the jelly, then it affects vascular sensitivity. And I think that's less important with actual duplex. So the plan is we're not going to shake the tube, and also we're also going to use globs of jelly because this is quite a viscous jelly. It's the one that they make. I have to say I've used it over the last week and it is very good. Now, to me, this is actually we will need some. Do you want to get some tissue, someone? Is that, Julie, do you want to get me some tissue? Would that be possible? Philip, well done. Thank you. Sorry, I forgot that. Just going to start by just picking up the arterial signals in the foot. And basically we turn them on. And what's quite important is that you put this... I'd normally put it in my pocket. Okay, I'm going to put it in my pocket. We'll put that somewhere else. Put it in my pocket there. Can you hear me? Yes. And basically, this is a very sensitive vascular. Philip, thank you very much. And it's important to remember when you're using these, lovely, thank you, is that this is a directional probe. It's picking up movement, and if you start to wander around, all you do is get a lot of background noise. So I hope you can hear me. So basically, you put it on the way thing, and this is immediately behind the medial malleolus, and we're going to angle it. Is there a volume on this? Well done, thank you. Of course there is.
If we put it, should be able to pick it better.
And that's basically the posterior tibial artery. And just to show you the angle, if we go directly at right angles to it, you tend to lose some of the actual accuracy. So basically we're trying to get approximately, and that's right in the center of the bone. And that's telling you that immediately that you've got a normal arterial signal, because it's biphasic. You can hear two sounds. Everybody hear two sounds? If you listen very carefully, you can actually just hear a third. So, okay, we're just going to use it for you. And the other thing to consider if you are on your own is to consider having a pulse oximeter. Pulse oximeter is literally just fits on the toe, and over a couple of minutes you'll find it'll give you an oxygen reading. These are about £40 each. And again, if you're a sole practitioner, a nurse assessing people, quite important because people quite like the addition of a bit of science to the consultation. And I think having these sort of gadgets, and a gadget like this, the other one I think is about 280, about £280, so a relatively cheap bit of equipment and quite useful. Now this is a bit more of a scattergun probe, and this will pick up. So we're going to change to this because I'm going to see if we can hear Denise's great saphenous vein, and we'll also just put it over the anterior tibial artery. So. Eight. That's 8 mega. That one's 8 megahertz, and this one is 8 as well. But you can get them in 3, 5, or 8.
You can get both of them in. You don't want 3 because it's more fecal.
And that's the anterior tibial artery. And you can, alternative, you can listen to it between the first and second toe flexor tendons, but that's again. That's You can just hear a second sound there. So
Pointing these out, Steve, for things we shouldn't be injecting.
that's absolutely right. Yeah, you're certainly not going to start injecting arteries, but they're just telling you that this person has normal arterial flow into their legs, and that's the important part. We're now going to see whether we can hear, and we'll just do it sitting as well. And I may go above the knee if I don't. Denise will certainly know where her great venous vein is. So she's going to point to where it will be. I think about there, will it? Okay. Let's just go above. Just picking up the femoral artery there, so femoral almost becoming the popliteal artery. So it's going to be quite close to that. Okay, don't actually hear that very clearly. Denise, you want to stand on the floor? If you turn around, hold on. We're just going to listen over the popliteal area. Popliteal artery, very clearly heard. Sorry about those noises off. Now, that sound is almost certainly the popliteal vein. And what that's telling us is that it's competent, and it's patent and competent. So patent means it's open, and competent means that there's no reflux, so we don't hear any noise of the flow coming back. Now if we go slightly lower, when you hear small truncal veins, they have a much higher pitch sound. What would you say that is, Denise? Still your popliteal vein?
No.
I think that's your small venous.
Yeah.
Okay. And again, we know that vein, whatever we're listening to, is patent and competent. And you go slightly further down the calf. And I'm pretty sure that's the small venous. When Judy's got her ultrasound out later, she will... Yes, that's the small venous. Okay. Now, I don't know how many people actually have and still use a hand Doppler? Well, quite a lot of you. Good.
For ABPIs. But,
Excellent for ABPIs.
Yeah.
I still have an old Huntley, which in fact has got duct tape holding the battery in, but it's still, I use it for ABPIs. Does everyone know what an ABPI is? Yeah. Okay, an ABPI, thought we might do it, is basically measuring the Doppler pressure, because it's using Doppler to listen to the artery. It's not the same as a blood pressure. So you have a blood pressure cuff on the arm. You then hear the sound at which the signal disappears and reappears, and that is the Doppler systolic pressure.
The systolic pressure is the first sound that comes in straight away. So once you increase the pressure enough to shut off
that is
the sound.
That's the pressure at which the flow is getting through using a Doppler. It's a different flow, it's a different pressure than a stethoscope. And then you do the same to a leg. You put a blood pressure cuff around the lower part of the foot, of the leg, and you measure the Doppler pressure in the foot artery. And in the ideal world, the Doppler pressure of the foot should be slightly higher than the arm, and it's expressed as a ratio. So a normal Doppler pressure of an ABPI is about 1.1, 1.808. If it's too high, if it's sort of 1.3, it's the sign that there may be incompressible arteries. Now this is where the confusion starts to occur, and that is that the arteries of the leg become incompressible. So they are hardened, and when you put the blood pressure cuff around the calf vessel is not compressed, and it gives you an artificially high reading. To me, rather sadly, it's quite an unusual thing to see on incompressible artery syndrome, but it's meant that nurses no longer trust ABPIs. And it's meant, in my view, that an awful lot of people are not getting compression on their legs because of anxiety about the accuracy of ABPIs. I don't know whether you agree with me or not, but that's my view. If the ABPI is less than 0.8, that means that the pressure in the foot is less than the arm, you start to suspect arterial disease. If it's 0.5, you definitely do not apply compression. And that requires almost certainly referral to a vascular specialist. Is that clear? Does that make sense? And it's worthwhile doing, and I think if you are a nurse in practice on your own, I was talking to a nurse last night who works in a vascular service, so she's got access to people being assessed beforehand. But if you haven't got access and requires a referral, it's quite a useful way of your patients knowing that you understand more about their legs. That's my view.